my history with standalone devices probably goes back 10 years or better. And I even go back a generation before that where we were using allograft versus a generation before that where we were using all autograft. So I've seen the whole progression of interbody devices that have been inserted in cervical and lumbar pathology. There's a lot of considerations that go into my selection of an interbody device when I perform an anterior procedure, whether it's cervical or lumbar spine. The first consideration is restoration of normal anatomy. And what I want to do is I want to restore the disc space height back to a relatively normal height as opposed to a height that's occurred as a result of injury to the disc or wear and tear. So you want an interbody spacer that is tall in stature, that's strong enough to sustain that, and is also close enough to the modulus of elasticity of bone. So in other words, it almost acts just like as another piece of bone. After that consideration, you want to think of the biology of the device. You want to think what's compatible in the human body, what's close to the elasticity of the surrounding tissues, and what's not going to result in infection. Anything that has titanium as opposed to stainless steel is more infection resistant. So titanium augmentation onto a PEEK device, a polyethyl ester propyl, is a better device, okay? The next consideration is what bony material are you going to use inside the implant and what's going to give you the best opportunity for a solid fusion. When you deal with PEEK devices or polyethyl ether ketone devices, they have a close bioelasticity to normal bone. So they react similar to the body to normal bone. They're also infection resistant.